Today's briefing will focus on a new P4AD report, Fiction versus Fact, Pharma's False Claims about the Unintended Consequences of the Inflation Reduction Act, which analyzes a months-long industry-backed misinformation campaign aimed at undermining the Inflation Reduction Act's drug pricing reforms. So we looked at a 4-month time period between September 2024 through mid-January 2025. And during that time, pharma spent more than $285,000 on digital ads across Meta platforms, spreading misleading claims about the law. In addition to reviewing over 125 social media ads, we also looked at op-eds that were in outlets like Forbes, the Atlanta Journal-Constitution, and the Fort Worth Star-Telegram, among others. And we also know that ads were running on Apple Music, YouTube, and so that $235,000 number was focused on the social media ads. So the number is much larger. We only analyzed the social media ads for this specific report, but we know that similar ads are running across other platforms. So a review of these ads and materials revealed 4 misleading and at times blatantly false central claims designed to create an unfounded fears about the impact of the IRA, a law that remains widely popular and one that is already delivering real savings for patients and will continue to do so in the coming years. So first, we'll hear from P4AD founder and president David Mitchell, who will walk us through the key findings from the report and break down how pharma's messaging misrepresents the law's impact. And he will address the 4 claims and provide fact-based rebuttals for those claims. And then we're grateful to have Lee Purvis, prescription drug policy principal at AARP, a policy expert who will discuss the tangible benefits of the IRA, the benefits the law is already delivering, including how it's reducing drug costs and improving access to essential medicines for patients. So David, I'll hand it over to you. I'm going to go off screen and I'll begin sharing my screen so folks can see the report here.
Okay, thank you, Emma. And thank everyone who has joined this call. And thanks, Lee, for joining us to backstop me, frankly. Nobody knows more about this than Lee. And so she agreed to come and be available to take questions about the IRA and how it's helping people. And she'll be speaking just a little bit later on. You all have the report, so I'm just going to take some time to highlight some key points. First, I want to note that almost all of what pharma claims about the unintended consequences of the IRA is based on studies it paid for or the source of funding for the studies is not disclosed. Now, these studies are remarkably flawed and misleading. One assumes only 2 provisions of the IRA take effect and ignores the other money-saving features of the law. It also assumes absurdly that Medicare beneficiaries take only 1 drug at a time, when in fact we Medicare beneficiaries take about 5 prescriptions per month. Another report purporting to project how payers will act nationally relies on only 23 interviews, hardly a projectable sample. Another predicts 135 fewer drugs due to the IRA, while the authoritative independent CBO projects 15. So the underpinning, the foundation for most all of the industry claims is weak, bought and paid for, and really manipulative. All the hallmarks of pharmaceutical industry lobbying going back decades. Let's highlight pharma's 4 principal claims and how they are completely false or seriously misleading. First, the IRA will increase costs for patients. Pharma says it over and over. This is frankly ludicrous. Can you put up the slide that we're going to insert here, please, Emma? CBO is abundantly clear that over time, the IRA is going to lower premiums and out-of-pocket costs for beneficiaries. And you can see it on this slide from CBO. This is without key policies, 88 billion, the cost, but it drops to 64 billion in I think that's 2031. Yep. And it's going to lead to a $25 billion decline in Part D enrollees' costs just in 2031 after more drugs are negotiated, et cetera. I don't know how it could be clearer that the law is decreasing right now as we speak costs for Medicare beneficiaries. You can go back to the report, Emma. Premiums will come down as more drugs are negotiated over and the lower prices take effect. Now, I can speak for myself. I am saving more than $15,000 this year on my out-of-pockets. That's from the out-of-pocket cap. The payment plan, which I enrolled in and does not charge me interest, will save me more money. Free vaccines save money, and I shopped and got a better plan for less money uh, because I looked around. And more people are saving from the expansion of low-income subsidies. This entire claim that the IRA is going to raise costs for patients is specious and it's offensive in the face of all the evidence that that is just not true. And don't forget, premiums have been going up in Part D since it took effect back in 2006. This is not a new development coming as a result of the IRA. And CBO is saying that the IRA is going to result in slower Part D premium growth. The second claim that pharma makes over and over again is that patients will experience reduced access to medications due to the IRA. Well, it turns out that there have been no significant decreases in formulary inclusion. All Part D plan formularies have to pass a rigorous review by CMS. When comparing 2025 formularies to 2024, CMS found no significant decreases in formulary inclusion or changes to tier placement of drugs. Prior authorization and step therapy rates are also generally stable. Now, utilization management is not new. It didn't get put into use by the IRA. It's been involved, including step therapy and formulary restrictions and prior authorization for years and years now. And the use of utilization management has been increasing among all health insurers over the last decade, and not just in relationship to drugs. PhRMA's figures come from a survey conducted by a firm that works almost totally, almost exclusively with and appears to receive its principal funding from the pharmaceutical industry. CMS has made it clear it's going to continue to monitor formularies and the application of utilization management in Part D to ensure beneficiaries have access to the drugs they need. The third big claim is that in response to the IRA, insurers will offer few Part D plans. Well, historically, fluctuations in the number of Part D plans is not new or unusual. Um, uh, Hang on 1 minute. The claim is based on two flawed assumptions. When it says this is going to hurt patients, the claim is, or the assumptions are that more plans are better, when in fact more plans are not good if they're not better plans. And that more choice is always better, which I can promise you is not the case. After going shopping myself this year, trying to figure out where I could get the best deal. After four plans, I was completely exhausted because it is so hard to wade through the details of the plans. Now, that isn't to say Medicare beneficiaries shouldn't go shopping, they should. But this is a red herring. There is, in fact, plenty of choice in Part D. And as I'm saying, unlimited choice isn't necessary for the program to work effectively. The average Medicare beneficiary this year will have a choice of 48 plans, including 14 standalone Part D plans and 34 Medicare Advantage plans. So, research indicates that the availability of a high number of plans can lead to confusion and patients picking plans that do not necessarily suit their interests. So we have to be careful when we hear that there are going to be fewer plans because they're not better plans. If they're not good plans, more plans is not better. And effectively speaking, in terms of practical application, it does create a problem, especially for people as they may age. And as a 75, almost 75-year-old, I can tell you it's true. The fourth claim is that the IRA is going to dampen future drug research and development. Well, the IRA doesn't institute price setting, first of all. It's important to say that. The Medicare Drug Price Negotiation Program created by the IRA specifically legalizes a voluntary and legitimate negotiation process with pharmaceutical companies and with offers and counteroffers. And in several instances in the first 10 drugs, an agreement was reached without the government giving the pharmaceutical company a final offer. The price reductions that resulted from the first round of Medicare drug price negotiation on those 10 drugs, uh, I produced an average savings of 22%. These negotiated prices, by the way, are higher than the still profitable prices being paid in other countries. And frankly, as an organization, we don't ever expect that the United States is going to pay the lowest prices in the world. In fact, we believe that the United States should continue to pay something closer to what other developed countries pay around the world in order to make sure that we are extending the benefits of prescription drugs and participating in extending the benefits of prescription drugs to people the world over. Now, CBO estimates the IRA will reduce the number of new drugs coming to market by only 1%, and I referenced the number earlier in this presentation. Drug companies themselves say negotiated prices are having little impact on their business or their bottom lines, and pharma companies have reported robust profits on recent investor calls, despite earlier public statements about how the IRA was going to result in terrible, debilitating profit loss. But it's not unusual for pharma to make statements that are later not necessarily true. Uh, Pharma companies, this is important, have also told investors that the outlook for R&D and new drug development is strong and that the U.S. continues to be the prime market for prescription drugs. Of course we are. We're the largest market in the world, paying the highest prices in the world, and we expect that will be the case for the foreseeable future. Uh, Bottom line, I want to mention the pill penalty, which is a very smart positioning and sales slogan for farmers' concerns about the difference in time to negotiation between small molecule drugs and large molecule or biologic drugs. We believe that this whole thing is specious. Uh, why is it specious? because we let the companies continue to set launch prices. And I don't know if any of you have ever helped run a business. I have run a business. And if someone told me that I was going to have a monopoly for 9 years and I could set the price to ensure a profit, a healthy profit, and I was going to get an inflation bump every year, uh, I could certainly figure out with maybe I would need help from actuaries and economists because math is not my strong suit. But I could certainly figure out what price to set to ensure I was going to make a boatload of money before I was going to have to face negotiation. So the idea that somehow it's unprofitable or so much less profitable to the companies to face negotiation at 9 years instead of 13 for small molecule drugs is frankly BS. Um, and I want to call to your attention, this isn't in the report, but we can send you the statement from Bio in the Trade Association in 2010 when pharma was fighting for 12 years, and a lot of people were saying for biologic drugs, and a lot of people were saying that biologics should only get 7 like orphans do. Bio said this: biologics research and development is a high risk endeavor with higher capital costs, higher material costs, greater manufacturing costs and uncertainties, longer development times, and lower late stage success rates than compared to small molecule drugs. They actually made an argument that they needed, well, it was 5 years for small molecules back then, 7 more years in order for the finances to work for biologics. Now they've decided, oh, well, we didn't mean that. What we meant was we want, now they're saying, the same time for all classes of drugs. They just want to make more money than what the law as presently configured will perhaps permit them, but in no way does that law prevent them from making a healthy profit on small molecule drugs. And their argument in 2010 is part of the reason that Congress gave them a longer time to negotiation when compared for biologics, when compared to small molecules. They gave them what they wanted, but they wanted it then. Now they just want more time for all drugs. And finally, I would point out that uh, there's lots more evidence. There continue to be acquisitions, big billion-dollar acquisitions by the larger companies of smaller companies with small molecule drugs. There was one just a couple of weeks ago. But the respected financial services firm Oppenheimer summarizes it really clearly. Quote, despite the IRA, small molecules continue to attract VC dollars, which is where the pipeline uh, from a private sector standpoint begins. Obviously, the pipeline begins back with the early high risk research that is financed by taxpayers through the NIH. So we believe that the 9 and 13 argument, the so-called pill penalty, is a crock. If you know how to run a business, you're going to make money on small molecule drugs, and really as much as you want. All you have to do is set your launch price to produce that outcome. You know how many people you're going to sell to, et cetera, and how many years you're going to have that price. So we strongly oppose efforts to undermine Medicare negotiation by equalizing the two at 13 years if they need to be equalized because pharma believes it's critical in order to have the same incentives for small molecules and biologics, then we would support equalizing them at 9 years. That's my presentation. And Emma, I think I'm ready to try and answer any questions folks may have. And that's why Lee is here too. So Um, Take it away.
Lee, I can pass it over to you if you have anything prepared, and then we can go to Q&A.
Yeah, thank you, Emma. And thank you to everyone who is joining us today. AARP has obviously been in this fight for a very long time and has always said that no one should have to choose between the medications that they need and other important things like their food and their rent. Unfortunately, high prescription drug prices have far too many older Americans to make these types of impossible choices. Our research has consistently shown that being able to afford medications is a top priority for AARP members and the broader 50 plus population. Today, nearly 80% of older adults report having two or more chronic conditions, things like diabetes and heart disease, debilitating neurological diseases like Parkinson's and multiple sclerosis. For those older adults and their families, prescription drugs are not a one-time cost. They are a cost that they and their families will be facing every day for the rest of their lives. Unfortunately, drug company pricing practices have been putting these products out of reach for too many people who need them. According to research that AARP released last month, the list prices for the 25 drugs Medicare Part D spends the most on, many of which were just selected for the second round of Medicare drug price negotiation, have increased by an average of 98%, or nearly doubled since they first entered the market. Our research also found that on average, more than 40% of the current list prices for these products is due to price increases that occurred after the products first entered the market. Unfortunately, these results are not limited to a few drugs. AARP has been tracking the prices of prescription drugs widely used by older Americans for over 20 years now, and we have consistently found that those prices increase faster than general inflation. In other words, this kind of behavior is incredibly pervasive. So not only are drug prices high, but they're typically growing every single year they're on the market. And to us, these aren't just numbers. They represent barriers for real people, parents, grandparents, friends, and neighbors who simply cannot afford the prescription drugs they need. That's why AARP, alongside advocates like Patients for Affordable Drugs, has been so focused on drug pricing reform. The 2022 prescription drug law that we championed is already delivering relief. Millions of Medicare enrollees now pay no more than $35 per month for their insulin and get free vaccines for illnesses like shingles. And even bigger savings just took effect. As of January 1st, the total amount that people in Medicare prescription drug plans have to pay out of pocket for their prescriptions was capped at $2,000 for this year. For people taking expensive drugs or people who might one day have to take an expensive drug, this is a huge win that's providing real savings. Our research shows that even after taking premium changes into account, 94% of enrollees expected to hit the new out-of-pocket spending cap this year will save an average of nearly $2,500. That's money they can use for groceries, rent, and other essentials. Before the new out-of-pocket cap, there was no limit on how much someone in a Medicare prescription drug plan could be forced to pay every year, and some were spending upwards of $10,000. The new prescription drug law changed that. Another incredibly important change is that the law finally allows Medicare to negotiate drug prices, which is something that AARP has strongly supported for decades now. The first round of Medicare drug price negotiation for 10 drug prices that will become available next year has already shown that this process will drive down prices and generate billions of dollars in savings for Medicare and its beneficiaries. With more drugs being negotiated every year and the new out-of-pocket spending cap in place, seniors are finally getting the lower out-of-pocket costs and lower drug prices that they need. For too long, big drug companies have profited from taxpayer-funded research, only to charge Americans more than anyone else in the world for the exact same drugs. And to be clear, AARP is very well aware that our members greatly benefit from innovative new drugs, and we want that innovation to continue. But contrary to the story that's often presented, we can have a system that rewards true innovation while ensuring that prescription drugs remain affordable. And arguments that the 22 drug law will negatively impact innovation are simply untrue. For example, according to S&P Global, the $100 billion in savings from Medicare drug negotiation that's expected over the next 10 years is equivalent to less than 1% of the drug company revenues, which really calls into question those apocalyptic scenarios that are currently being presented by drug companies. Furthermore, there is no meaningful evidence that drug development is slowing down due to the 2022 law. In fact, since the law passed, and as you've heard, drug companies have actually increased their investments in research and development. AARP knows that lowering prescription drug prices remains a top priority for our members, and we're going to keep pushing to lower drug prices until everyone can afford the drugs they need, because we know that prescription drugs don't work if people can't afford them. Thanks again to Patients for Affordable Drugs for inviting me to participate in today's event, and I look forward to your questions.
Thank you so much, Lee. So now we can open it up to the floor to questions. You can drop questions in the Q&A. You can also raise your hand and I can let you off mute, but we also have some pre-submitted questions that I'm going to start off with while folks stick their questions in the chat. So David, to you first. According to the report, PhRMA's 235,000 digital ad campaign misrepresents the IRA's benefits. You talked a bit about this, but what key data from the report should reassure patients that the IRA is effectively lowering their drug costs?
First of all, it's not just the data, it's the experience that millions of patients are having. I did not list the $35 out-of-pocket cap for monthly insulin supplies in my list of ways that millions of people on Medicare are saving money. Of course, when they go to get recommended vaccines that are covered, those are free. Uh, they People who take very expensive drugs like I do, and Lee referenced how many, uh, have will hit an out-of-pocket cap, the out-of-pocket cap at $2,000. I hit it in January, and I put myself on a payment plan, and so now I'm going to get monthly bills for the 2 grand that I didn't pay. I left the pharmacy paying nothing, knowing I'm going to get the bill. And so they're going to experience the savings over time. Uh, I didn't mention the ones that are hard, the ways that are harder for people to see. The inflation rebates are holding the line on some Part B drugs, and they don't know it. We are trying to do better to educate patients that instead of paying their coinsurance on list, which was the practice before the enactment of the IRA, coinsurance is now paid on the negotiated price. So if you pull down the list, like for Eliquis, which I take, I think it was pulled down 57%. Your out of pocket is less, even if you don't hit the out of pocket cap. As you're on your way up toward it, you're saving money every time you get a prescription, which means that over time you're getting more value for less money. Um, so there is the experience of it, and there is the work we have to do to point out some of the elements that are less visible to people. And I have to compliment AARP of all the groups trying to say, this is what you should expect, this is what you should look for, this is what's happening, make sure you take advantage of this. AARP does a really good job talking to people to help with that, and they talk to a lot more people than we do. Lee, would you add anything to what people should know about?
Yeah, honestly, there's so many benefits included in this law that honestly, it's a bit of a struggle to figure out how to convey all of them to all the people who need to know about them. I personally have heard from members who've been surprised by the fact that there is now a $2,000 out-of-pocket cap, and so there's definitely some work to be done in terms of educating people. But the one thing I like to convey, back to kind of your hidden benefits, is the reality that this really is a law that helps everyone, whether it's you're being helped at the pharmacy counter, or you're being helped as someone whose premiums are coming down, or you're being helped as a taxpayer who helps fund these programs. This really is an issue that impacts absolutely everyone. And so, to the extent that this law is helping to reduce out-of-pocket costs and those high prices that are underlying a lot of the other forces we're seeing in the healthcare system, that's incredibly important. And it's important for people to understand that they too are benefiting, even if they aren't in the Medicare program.
Thanks, Lee. And building off of that, given obviously the rising costs of prescription drugs and the price hikes you were talking about, how can the IRA be used as a model to address systemic issues in drug pricing and ensure broader access to medicine for all patients, particularly seniors?
Yeah, I really like the use of your word model there, because the reality is, at least for someone like me who's been working in this space for a really long time. This really addresses both sides of what I always refer to as the affordability coin. One, it is helping to lower out-of-pocket costs, which is helping people directly in terms of making sure that they can better afford their prescription drugs. But it's also trying to address those high prescription drug prices, whether it's the launch prices or how high those prices get after they are launched. It's helping to bring down those prices through negotiation or trying to curtail those price increases through those inflation-based rebates. So it's addressing those prices that are driving those high out-of-pocket costs. So it's bringing everything together. Contrary to a story that I think is out there, the reality is you can't just control out-of-pocket costs because those costs have to go somewhere. And where they ultimately end up is in people's premiums. So if you just control out-of-pocket costs, what you can ultimately do is push the cost of coverage out of reach, which is incredibly harmful, obviously. So you want to make sure you're addressing it from both sides to make sure you are making it affordable for people and then making that coverage affordable as well.
Thank you so much. And this is a question to both of you, but David, I'm going to send it your way first. How do you think the false narratives from Big Pharma could undermine the progress made by the law and potentially derail future negotiations? And in that same vein, why is it crucial to counteract pharma's misinformation right now?
Ask me the first part of that again. I was trying to unmute myself and
No problem.
push the button.
So how do the false narratives from Big Pharma, the claims that we looked at in this report, how could they undermine the progress that has been made by the law and potentially derail future negotiations?
Well, pharma is all about stopping Medicare negotiation as obviously a number one goal. Uh, they filed suits in 10 circuits to stop Medicare negotiation. And it's not because Medicare negotiation is debilitating to them. They've made it clear it's not. They can live with the negotiated prices on the first round, and if it keeps on that way, I assume they can continue to live with it. It really is about the power, this industry trying to restore its unfettered power to set the prices of drugs for everybody in this country, to dictate the price of drugs to everybody in this country, something they can do in no other nation on the planet. And we gave them a sweetheart deal back in 2003 at the time that the Part D benefit was enacted. Many of you who have covered this industry for a time know how that happened, that, a member of Congress, Billy Towson, stuck in the non-interference clause that precluded negotiation by Medicare directly with the drug companies in the dark of night, and it got enacted. And within months after that, Billy Towson went to work as the head of pharma for $2 million a year. That's the type of industry we're dealing with. And they wanted that sweetheart deal. They paid a lot of money to get it, and they're trying to bring it back. So we have to remember this is about this one industry's economic power over the people of this country. And that's what they're fighting for. So they're fighting in court to wipe the whole damn thing out, Medicare negotiation, and then they're pushing bills to undermine the ability of the law to save as much money as it's written to save. Now, it's also important for patients that we understand that if you did increase prices too much, if you did decrease prices too much and profit too much, you would at some point down a curve undermine research and development and innovation. We don't want that. I now have two conditions that are being life-threatening, incurable conditions that are being managed with prescription drugs. And I need more innovation, especially for one of them that could kill me at any time or cripple me mentally. Patients care deeply about innovation. And the point I'm trying to make is that the IRA actually strikes a balance. And we see that balance playing out when the industry says, no, we went back and forth with pharma, and we got a deal that we can work with, and our profits are going to be strong, and we can invest in R&D, and we are. And we want to keep that balance and make sure the law stays in place. So all of these claims about, oh, there are things happening that people don't understand, the unintended consequences of the law is unfortunate. And the fact that we have two bills in Congress right now, one on well, it hasn't been introduced in this session. The 913 bill hasn't been, but the orphan reforms have been reintroduced in this Congress. Uh, it's all about undermining the extent and reach of the law and the law's ability to do what is necessary that Lee mentioned earlier, which is lower prices so we can keep the lower out-of-pocket features of the law. And it's important to bring our defense. I don't mean defense. It's important that we bring our efforts to expose the lies and misleading statements and cooked up research uh, to everyone who will listen, and especially folks in Congress, lest they be somehow misdirected and buy into the BS that pharma is peddling.
And kind of building on what David said, I think it's really important for people to see that this can be done successfully, because the drug industry has very effectively used scare tactics for a very long time that effectively said the sky is falling every time there is something at the state or the federal level that is trying to address high prescription drug prices. And the reality is that is never proven true. They are one of the most profitable industries in our country. The other thing to keep in mind is, obviously there's a lot of attention being paid to what the drug companies are saying because they're certainly loud, but they also have a platform available to them that is not available to the real people who we are talking about, who are struggling, who really are going to be benefiting from this law. And so that kind of goes back to making sure that people are aware of this law, its benefits for them, and again, that it is being done in a thoughtful way that will help make sure that innovation continues, but also make sure that people can afford that innovation. And that is kind of, I think, the prevailing importance of this law and the efforts to make sure that it continues to be implemented in the way it was intended.
Thank you both. I'm not seeing anything in the chat. So that's all the questions that we have, but if there's anything else that either of you would like to add that was maybe missed, feel free.
I don't have anything to add except to thank folks who took the time out to come and hear this and hopefully to read the report. And we really appreciate it. As Lee said, pharma has unlimited resources. Monopoly industries, by definition, have unlimited resources to maintain their monopolies because if they have to spend money to lobby or make campaign contributions or finance bogus research or pay fake groups with nice sounding names to carry their water for them, they just raise prices. And that's one of the reasons it's so difficult to do this work is we're up against, Lee said, maybe one of the most powerful lobbies in the country, I would say in the world. And so the opportunity to try to set the record straight is important, and we thank all of you who have taken the time to listen and to read the report today.
Thank you all so much. Thank you, David and Lee. This is being recorded so we can share the recording and the report around after the fact as well. But again, feel free to reach out to me with any follow-up questions and I can direct you to the right person. All right. Thank you all so much. Bye-bye.